Welcome to Everything ALS. Tonight's program is about COVID-19 and how we're going to help you deal with it and get through it. We have three special guests tonight. We have two respiratory therapists and we have a physical therapist. So we're going to be asking them questions tonight. And if you have a question, all you need to do is type it into the chat box and we will pick up those questions. Our friend Zoe is watching the chat box. And Afia, good evening. Good to see you. So I would like to start. Gerald?
Sure.
Good evening. I'd like to just say a few words. Gerald Reynolds is a licensed respiratory care practitioner and a nationally registered respiratory therapist. Gerald, can you tell us what you've been up to?
I've been up to a lot of neurology because all my graduate work is in neuromuscular disease.
Could you turn your microphone up just a little?
Oh,
thank you.
Okay, so I'm an assistant professor of neurology at Ohio State, and my practice is with neuromuscular patients. Probably my biggest focus is ALS.
Beautiful. And how long have you been working on the ALS part of your work?
Well, I've been a therapist for 38 years, and ALS has been one of my prime motivations for 21 years.
Beautiful. Thank you so much for joining us tonight.
Thanks for having me.
Yes. Afia?
Hi.
Good evening. And
Good evening.
Welcome to our program. And thank you so much for spending your evening with us. And can you tell us a little bit about your background?
Sure. I have been a registered respiratory therapist for 23 years. In the hospital setting for 19 of those, and then these last 4 years, a little over 4 years, specifically with a DME company. But our primary, probably I want to say 90% of our patients we see are ALS patients, the other 10 being neuromuscular, other neuromuscular like muscular dystrophy, multiple sclerosis. So we see our patients in the home, not lately, but every month, and manage their ventilatory, of course, ventilatory care and all of their treatments. So yeah, I'm looking forward to this evening. Please ask any questions you like.
Okay, beautiful, because I'd like to start off with you in this question. It said, what would you say is the biggest impact to ALS patients due to the COVID-19?
So specifically with us, you know, the main thing we've educated all of our patients. Where I work, we see patients all over Texas and Louisiana, and we've told everybody what everyone already knows. Be very, very strict with hand washing and be very strict with who can come in. I mean, they're your grandkids, I know, but you got to be strict with them. Because if ALS patients are, you know, you're a much higher risk. So the impact of COVID-19 is, yes, make sure that everybody that comes in washes their hands. If you have a family member who works in a hospital setting that does get exposed, then, you know, we're like, come in the door, change, go somewhere, put your clothes, you know, your scrubs in the wash. Don't even get close to any family member. Besides that, the one thing that also has changed is that equipment, supplies. We are limited now with supplies that are, a lot of them come from overseas. So we're telling all our patients to be very vigilant about cleaning their supplies. We don't know when they're, you know, we're hoping it will be better, but we just don't know. With the COVID-19, because we are going to put our patients at risk if we go see them, we have been doing a lot of FaceTime calls. It's been going really well, actually. Out of all the 500 plus patients we have, zero so far have had coronavirus. So we've been very blessed. I think it's because they're being very strict about who can come in and out of the house. I think it's because our patients are being very vigilant about cleaning. The virtual, well, you know, I would visit physically, of course, assessment and look at the ventilator and their devices. But it's been okay, you know, honestly, it's been not too bad. We do it virtually where I ask them to put their phone towards the ventilator to see the numbers. I watch them do their cough assist therapy, for example, if they have that. So that for us, for me personally, the impact has been going well. There are times where we have to go see our patient and we go through our protocols. Nobody's been exposed. I haven't been exposed to anyone. If we have, we wait 2 weeks. So yes, we do go and see patients if we have to. It's absolutely necessary though.
Beautiful. Do you find that all of the patients that you go see have protective gear on?
Absolutely, yes. Yeah, I mean, like, if they could wear like 2 or 3 masks, they probably would. We wear our N95 mask, we gown up, we wear our gloves. It is such a big risk for me to come from the outside to see my patient who has ALS and put them at risk of COVID when their immune system, well, their lungs are already possibly compromised. So yeah, everybody's just really careful, and we just really try to limit it.
Beautiful. Thank you for that information. Gerald, I'd like to ask you, in comparison with traditional symptoms of ALS, how would a patient show the symptoms of COVID-19? What would be the difference?
Yeah, that's a tough question, but a good one. The COVID virus morphs, it changes, and it affects people we're learning very, very differently. And one of the many, many facets of the disease is we're now starting to see patients that have neurologic deficits from the COVID-19 virus. And if you put that on top of the ALS patient, then it's going to be equally confounding. And certainly don't want to spread any kind of panic, but it is very real. And one of the things that we're starting to see now in the hospital is symptoms very similar to Guillain-Barré. And that's not just for ALS patients, that's for everybody. But as you can see, it's possible to have more than one neuromuscular disease. And that is certainly a concern.
Do you find that do you personally go and treat patients?
I see patients in my outpatient clinic. I don't go in hospital anymore. And unfortunately, I was doing face-to-face visits in my office up until 2 weeks ago. The state of Ohio, which is where I work, has stopped any kind of outpatient pulmonary function testing, which of course, all you guys know, is critical for me to figure out what to do with my patients. It's kind of what we do first, and then we know how to treat the patient and where to go. So oh gosh, it's been so frustrating for me. I do the best I can with our teleview, our video visits and our telephone visits, and we have something called My Chart at OSU where I can talk to them via their computers. But it's tough. It's tough. I'm kind of a hands-on kind of a guy, and it's made it difficult. There's a roadblock there that I wish I could make it go away.
Well, we're all here to help you in any way possible. We're trying to gather as many patients as we can so we can get testing done and help you to solve this problem. So we really appreciate that you would come on tonight. And I would like to just step over to Silver for a minute. Silver Denton, welcome. She's our physical therapist tonight, and she is from the outpatient near clinic at the University of Washington Medical Center. Good evening, Silver.
Hi, good evening.
Hi. Could you tell us about some of your experiences lately with the COVID-19 and your physical therapy for the ALS patients?
So since we are in outpatient clinic, we limited access to our clinic. Those are folks who we clinically think that at a higher risk than we normally do not ask them to come in. So, but actually today I had a patient came in, one of my ALS patients came in for wheelchair need. Despite the fact that he lived far away and it was difficult because the clinic is we have a very low census at the moment. We do a lot of telemedicine, but because I have a low census, I was able to spend a couple of hours with him to find very suitable wheelchair for him. So it's a luxury for me. Like normally I spend an hour, but we had a 2-hour session today. But that's because it's a device related one. But if I see my clients who has ALS, who needs exercise program that I need to kind of help him develop so that he or they can stay strong and active, I will probably go with the telemedicine because I don't want to risk their safety. So we are seeing way less patients. We see way more through telemedicine.
Do you feel that the telemedicine is what degree would you say that's effective instead of having the physical appearance from a patient?
You know, surprisingly, it's high. I was very skeptical. I'm very hands-on person. I love hugging my clients. I don't know like if it's gonna last or not. Maybe when we reopen, my style of treating patient will be a little bit different. So I was quite skeptical about how much I can do for them, but I would say like I can do 80% of what I can do at clinic hands-on. So I'm pretty satisfied with how we are doing, how rapidly we changed to telemedicine to assist our clients.
Do you think that the clients feel secure with telemedicine?
I think so. Like we use using not the Zoom the way that we use, but it is through our documentation system, which is Epic. So we connect through that Epic system. There's always a chance of hacking, right? So we normally, at the beginning, we tell them there's a chance. Would you still want to proceed? So oftentimes they want to do it because they want to check back with me what they are doing, how they are doing. And also like a lot of it is this uncertainty make you, am I doing it right? Am I doing too much? Is this okay? Should I do this? Should I not do this? That like coming from clinicians saying that yes, you are doing it right, continuously do it. Kind of getting encouragement from me seems to be also very positive effect on them too.
Beautiful. Thank you so much for that. I'd like to go to Afia. Afia?
Afia.
Yeah, Afia. Thank you so much. Are you using telemedicine?
We are. That's pretty much what we're having to use only. Yes.
Okay.
And it's been well. It's been going well.
So so you know, me when I go to the doctor's office and I see the television, I have a little problem with feeling secure about that. So I'm really glad that you feel that your patients are feeling secure over the TV. That's a big plus because of the illnesses that we have taking place now. Seems like everybody is Zooming and being grateful that they can communicate. So I'd like to go back to you, Silver. Silver, when you're fitting somebody for a wheelchair,
Yes.
how expensive do the wheelchairs become?
I would say 20 to maybe $30,000.
Do you see that the $30,000 wheelchair has more to give to a patient, or is it custom to the patient?
Yes. If it is not custom, I don't see clients who can use over-the-counter one. I don't see them because they don't need my specialty. So when I see folks with that, we call it like a rehab wheelchair, rehab chair. Those are the ones that come in, and I work with people called like ATP, like adaptive technology professionals. So they are the one who's specialized in the equipment. I am specialized in our body, like a movement and body and comfort. So, and my clients come. I always try to remind my clients that they are their own specialist because they live in their body 24/7. I'm not there. So I tell them, I'm a movement specialist. You are, so John Doe, you are John Doe's specialist. When two specialists come together, we can make things work better. And on top of that, like now I have like a technology specialist. So three of us like make it work. So they like design the extension of their body, I call that. The wheelchair is like that extension of their body so that they can do the things that they want to do. So we just kind of fit to their need.
Beautiful. I myself had a $26,000 wheelchair that would stand me up, lay me down. It made life for my wife much more doable since my caretakers weren't there 24 hours a day. So yeah. I really feel that the wheelchair component is super important for the patient and the caregiver.
I agree.
I agree. Dr. Reynolds, can I ask you, I want to come over there. It says there's been talk about the benefits of proning therapy.
Yeah.
What are your thoughts as a preventive measure? Also, if you can explain, what is the proning?
Proning is a way to have the patient in their bed with them being face down. And it's usually done with what's called a striker bed or specialty beds, where it's not like your face is in a mattress. There's cutouts so that you can be comfortable as possible in that position. But it's very simple. It's gravity. If you have somebody in a prone position, it does increase the blood flow to the alveoli, and that's where the gas exchange occurs in the lung. And it does, in some patients, help with ventilation. Now, the one thing about this virus that it seems to be emerging is that high positive pressures are not a good thing. And anything we can do to not have to go to higher pressures to adequately ventilate the patient, we want to do. So this is it's an old thing. It's nothing new, but it's something that we pulled out of pulled it out and put a new use to it, a new use, so we can hopefully ventilate these very difficult patients. And please don't confuse with, I'm not talking about ALS. I'm just talking about anybody. And if they're on a ventilator and they have the virus, we don't want to get too much pressure in the lung because it's a very fragile thing. And this is just one of the many things we're trying to do, to not do more damage, do more harm than good.
Thank you. And is that a common practice?
In the bigger centers, I think it probably is. At OSU, I know they're certainly doing it. But once again, this virus with anyone, not just ALS patients, it really varies. The way it affects individuals is very different. In that respect, it's like ALS. ALS hits everybody in a little bit of a different way. And it's hard to predict which way it's going to go. So, yeah.
In your experience with ALS patients, have you found that that toxic chemicals or heavy metals have played any big part? And do you suggest for people to do chelation?
Yeah, definitely. I've seen a lot of Agent Orange patients, and I have a lot of Agent Orange patients. So that certainly would be your toxic chemical. Chelation is something that I know what it is, but I'm not even going to pretend to know that I've ever done it or had anything to do with it. So I don't want to comment on that one, but definitely toxic chemicals. Yeah, that's way up there on the list.
Okay, thank you. I had chelation therapy, and my lead levels were up to 49, and 5 is normal. And so I went through chelation therapy for 7 months and was able to bring my lead levels down to 16.
Wow. What was the source of your exposure?
My exposure was when I was a small child in St. Louis, Missouri, by a lead smeltering plant.
Oh my.
And so ever since I was a young person, I've had lead poisoning. Nobody ever really realized that until I went and got chelation therapy. Then they told me, hey, your lead is off the charts.
Wow.
So it's just another thing that's creeping up on people that they're not aware of. Mm-hmm. So is there any testing that you would suggest for people? Just, you know, if you're 45, 50 years old, you've been exposed to a lot of things in life.
Right.
Is there any testing that you would suggest that people, even if they're feeling fine, that they should get?
Oh, even if they're feeling fine. Well, I guess if you have a familial history of, say, ALS, there's probably some things that you would want to look at. But we're much more, at least at Ohio State, and I think most major centers, we're very much into genetics, and we have come so far in being able to identify the problems with the chromosomes, where the damage is, what kind of damage it is, and that's really a big part of our focus is mapping that, tracking that. I know we're just wrapping up the Answer ALS study, and it's for the Niels Foundation. It's a big consortium of hospitals where we're doing testing and we're collecting data. And that's the thing about ALS is we need more and more and more data and genetic information. And the more we get, the more we're going to have a much better chance, in my opinion, to treat the disease, and hopefully someday that we can defeat it.
That's beautiful that you're looking for patients, because that's one of the biggest draws that we have, is that if we can bring patients together, we can bring them to you. And we're really looking for 200 patients who we feel that we could get a good survey of what was taking place with them. So we're looking forward to sending you as much information as we can so that you can give it back to us with an answer.
Oh my God, we'll take it. We'll take it. Okay,
well, you know what? Thank you so much for dedicating like 30 years of your life to this research that you're doing. Is it respiratory therapy? Do you feel that the ALS patient, that is something that is going to take them down because of their breathing already being hard?
Compromise, are we talking about the COVID virus? Is that?
Yes.
Yeah, absolutely. It would be much harder for someone that has the muscles of respiration that are compromised from the ALS, particularly if it's a significant level, then yes, they would have a lot tougher time fighting this. There's no question.
Thank you very much. I'd like to go back to Afia. I hope I'm getting that right, dear.
That's right.
And I'd like to ask you, when you visit or when you did have people come to visit you, did people bring their caretakers with them? Mike.
Yes, if they could not bring, a family member couldn't make it, because it's always very difficult, because since the patient is not working anymore, the other family members are definitely working. Yes, the caretakers come.
And do you feel that the caretakers are educated enough to, I mean, have you met caretakers that you feel are competent to be taking care of the patient, or have you seen any lack there?
Yeah, I mean, absolutely, they definitely are competent. This disease is a 24-hour, disease, and I think the hard part is finding that caretaker. It's very difficult. Once you do, it's a huge blessing. We have to make it a point to really, really train and retrain and re-educate everyone, especially the person who's going to be with the patient, the most. So I think the hard part is finding that person, because the other family members are always working. It's just really, it's all very hard. But yes, very competent.
I found that very hard too, because I had caretakers who were just friends at first, and they were very uneducated on how to move me. And it was very painful at a lot of time. So I'd like to ask mistakes that happen with the patient, probably from the caretaker. Have you noticed things going wrong?
I think that we get a lot of pictures sent to us. Is this connected the right way? And is that, if they're on a device that has an alarm or something, then of course we would know right away. Okay, but it hasn't been too bad, honestly. I think that this is a very trying disease, and I think that the caretakers are overly protective, actually, and so they're very, very careful. So I don't. There have been mistakes, yes, but they're very minor. And if something where it has to do with the breathing or something, then the ventilator will alarm, or we would know.
Thank you. Could you give us some common exercises that ALS patients at home could just do in general to keep their bodies moving in some way?
We always
like strengthen their bodies or their lungs?
Yeah, like I think it was Dr. Reynolds who said earlier, every patient with ALS is different, and it's incredible. Every single patient progresses differently, can do different things. So whatever therapy they have currently, we'll always say continue that. Deep breathing is also always very important. There's like wisdom in yoga, because centuries old, but it is absolutely. I think that most patients are probably doing that. Most people are probably doing that already. Not, very, very, very deep breathing, and a hold at the top, and then exhale. Where, with this coronavirus, it's already a bit stressful. It is definitely very stressful for people with ALS, and so we try to not say, oh, by the way, do this extra and do that extra. We're really not doing that too much. Do your therapy, do your regular stuff that you've been doing on a daily basis every day. Just be more careful with who comes in and out. It's more of that. But if there is, if they ever have any issue, any concerns, like, oh, can I do this? It's more of a one-on-one. Okay, do you have a spirometer at home? What are you using currently? it's more of an interaction like that.
Are there any exercises? I know you just mentioned about the breathing. Could you say, mention just another exercise with the breath that people could practice?
I believe that if it depends on if you have, there's a bunch of little devices that will, like a flutter device, I don't know, I'm not really sure, how many patients are using those right now. It's nice to have something on the other end of your breath that will vibrate, have that vibratory reaction in the lungs to move secretions. We really rely on the cough assist device for our patients. I think the name is so much more than just cough assist. We have a lot of bulbar patients who cannot cough. It's really hard for them to take a deep breath. And that specific device will, if it's set correctly, of course, will help in that in a huge way. The exercises are, it really depends on where the progression is of the ALS, but those type of devices help tremendously.
Thank you so much. Silver, can I ask you, what are some of the exercises or activities patients can do at home during this time? What would you suggest?
So before I get into PT section, can I tag along with what Afia said? So when it comes to deep breathing exercise, I think sometimes it is hard for people to visualize or to feel what does that mean, right? So what I would say, what I would have patients do when they can do nothing else, but they don't want to do, they are too exhausted mentally, psychologically, and physically too, but they feel like they have to do something to help themselves. What I would say, find a comfortable position. I'm going to position myself a little bit differently now. I will move so that you can see me what I do. Can you see me? I'm a little bit now reclined, right? Can you see me?
Yes.
Yes.
Okay.
Yes.
So I will have people sit like that and then put their hands on the tummy. So just for the first about 5 to 10 repetitions, just breathe normally the way you normally breathe and feel how your stomach moves. So your belly will go up as you breathe in. Everybody who's on the Zoom with me, sit back, put your hands on your tummy, and let's breathe 5 breaths together, okay? Breathe in and breathe out. Breathe in, out, in, and out. Breathe in and out. Your focus is how your a belly moves with your hand, okay? So you can see how your hands are going up and down. As you breathe in, your belly comes out. As you breathe out, your belly goes in. So that you can facilitate yourself by pushing your hand gently with your stomach as you breathe in. So you breathe in, but your hand gently pushing out. So that you are basically giving tactile cues. You are telling your body what to do. And as you breathe out, you will gently bring your hands in so that you are becoming extra layer of your abdominal muscle group. So they squeeze in, your intestines will go up, push your diaphragm up so that it can squeeze lungs so that your lungs can get rid of like a carbon dioxide. That's a one way of do more efficiently doing your breathing exercise. Another thing is when you breathe out, pretend you have a straw in your mouth so that you are breathing out through your pursed lips so that you are increasing the like a negative pressure in your lungs so that you can empty your lungs better. Okay. And I have a couple of like exercises I want to tell you to, so that we can all do whether, while we are in this quarantine, basically. Just like Afia said, the things you've been doing so far, continuously do that. For whatever reason you haven't done anything, you don't have your routine exercise, these are the things I think help you think what to do safely. So let's say you are recently diagnosed with ALS and you haven't fallen, so you still have anti-gravity strength. So you can resist a little bit, like when somebody push you, then just to do the strengthening exercise. Walking is a good one, but we cannot go out. Just pace yourself in the house and try to do exercises like half an hour a day. The one, like, I think that the ones that I want to show you is like those are folks like who's, you are like a middle stage of like ALS progress, and then you had fallen. Then I want you to do the exercises in sitting. So the exercises I like you to do is simple one. I will start with like from the bottom up. So you will do this knee straightening basically. This seems simple, but this simple exercise work on your quadriceps, which is major muscle when you need to stand up. So this is a good exercise. And another one is this is actually my favorite simple exercise. You will squeeze your butt cheeks and relax. I'm not moving anywhere else. I'm just squeezing my butt cheeks together and relax. Squeeze and relax. So those are like very two simple exercises that you can do. If you can find a safe place, like for example, you are at a dining table, chairs right there, tables are here, standing up, sitting down, standing up, sitting down. This is another good exercise. Very simple, very doable. You can do like 10 repetitions, 15 repetitions. The key is you shouldn't overdo it. How do you know you're overdoing it? If your body is sore, even after 24 hours, that means you overdid it. Okay? Another one is if you cannot use your muscle against the gravity. Let's just say I have a hard time straightening my knee like that. Don't add any weight. If you don't have any strength completing the range of motion, what the muscle has to do, if you cannot complete the motion, adding a weight is going to fatigue you so much. Basically, you're overworking the muscle group. So don't do that. Use like just like using your body weight. Don't add weight. And those are folks who are kind of late stage of ALS. The best thing is like a range of motion exercise, moving your arms and legs. If you cannot do it yourself, asking your loved ones, caregivers, and do it like a regular basis. I think that should be done daily, 7 days a week.
Thank you. We really appreciate that.
That was excellent.
I'd like to go back to you,
Big
Dr.
Finn,
Reynolds. Jerry?
question, Big Finn, real quick, Silver. We had
Yes.
have a patient who asked specifically about your belly breathing exercise. If you don't have a mobility in your hands,
Mm-hmm.
can you have a caregiver be the tactile reinforcement?
Yes.
Okay.
Yes. So that is, Sarah, it's not going to be, I'm not pushing them, right? My hand is just resting on it, and like it should be like, if you quantify it, it's going to be like just the weight of your hand. That's it. When you're coming out, you don't do that. When the belly button is coming out, it's there. The sensation alone is enough to get the cue. But when you are helping them kind of breathe out, just a light touch, gently guiding in that way.
Okay. Yeah, so we had a patient just specifically ask about having assistance in those exercises if they don't have full mobility in their limbs.
Yeah.
So thank you for that. That was great. Go ahead, McFinn. Sorry.
Okay, thank you. Dr. Reynolds, Jerry,
Yes.
for patients who are on more invasive support, are there techniques that caregivers and family members can perform to either help decrease their risk or provide extra care during this time?
Define invasive. Do you mean trached or intubated?
Yes, yes.
Okay. Well, if that's the situation, then definitely a cough assist machine is where you want to go, because that is a very effective way. It's certainly not a pleasant way, but it's a very effective way to break up secretions and enable you to remove them from the lungs. I've got lots and lots of exercises that I do with my patients, but when it's invasive, let me take a step backwards. Look, most people that have ALS, their lungs are normal, okay? And you treat them much differently than a pulmonary patient that has lung disease. It's a whole different ballgame. And if you're giving them minimal pressures and volumes and ventilating them, if they're intubated, you're usually going to be in good shape unless they develop a pulmonary infection, and that changes the ballgame. And once you get to that point, then probably our biggest weapon is the cough assist. But our feeling is the way we treat our patients, we don't want our patients to get to the point where they need a cough assist. And that's really the focus of our care. And yes, I thoroughly believe in exercises and the things that you guys are talking about and the things that I do. But we try to avoid that. And in many, many, many cases, it is avoidable. But if you're invasively intubated or trached, then that's a different ballgame. And probably the best thing to assist that, there's different things you can do as far as oscillating chest wall pressure or different types of nebulizers. But once we're kind of getting away from ALS here, then we're creeping into the lung disease area. And I guess what I'm trying to say is we really want to try to keep our patients from getting there.
Well, thank you. Do you find that, once again, are you seeing patients yourself?
Oh God, yeah, yeah.
Okay. Well, then, can you explain, you said a word about the GASC, or there was some, in your last message.
Okay.
Anyway, the word, I didn't know what it was, so I'm gonna leave that go.
Was it gas exchange?
Yes. What is that?
Are you familiar with alveoli, the little sacs in the bottom of your lungs where the gas exchange occurs with oxygen and CO2, where that's brought back and forth from your bloodstream and regulated?
No, I'm not familiar with that.
Okay. Well, it's the bases of your lungs primarily. Gas exchange occurs, and that's where we can utilize oxygen and get rid of excessive carbon dioxide. And that does lots of physiologic things, but it's very, very, very important. And I think maybe you were thinking back to when I was talking about proning, because proning does help with that, because it increases your vascular supply, your blood flow to the alveoli, and it helps to improve gas exchange. And that's how that works.
Thank you.
And please ask me more questions if I'm not making it clear.
Well, no, you're very clear, and we're very grateful that we got you to spend your evening with us. Is there anything that you're hearing tonight that you haven't heard that should be brought up?
Sorry, McFinn. I'm just going to take this opportunity to bring up some of the questions that are in the chat already.
Thank you.
So one of the questions that the participants asked is that for bulbar onset patients, what suggestions can you offer that might help with saliva?
Yeah. Oh, I'm sorry. Go ahead.
No, go ahead.
Well,
That's
there's
for
a
you,
lot of
Tony.
medications. Amitriptyline is the one we use the most. Oh gosh. Well, there's a whole list. I don't want to be listing a bunch of medications because I don't know you and I don't know your physiology and your history, but we've got about 25 different drugs that we can pick from to help with that in our bulbar patients. And also, of course, you can use Botox to the salivary glands, and we do that as well. It's very effective. So it's ALS. I mean, everybody's different. So you got to tailor your treatment to the patient's needs. But there's a great deal that we can do, and that we do.
Great, thank you. Zoe, next question.
Sure. Another question that somebody asked is, have you seen success with amino acid injections into the muscles, such as GAC? I'm not sure if you can answer that, but if anybody has any information about that.
I've only seen anecdotal information on that, and I'm highly skeptical. That'll be my answer. I'm skeptical.
Let's see if, Silver, do you have any comment on that?
No, I actually, no.
Okay, thank you.
So, sorry.
Okay.
And Afia, do you have a comment on that?
I don't either. But yeah, just to piggyback off of what Dr. Reynolds was saying, there are many different things that ALS patients will use to maintain and try to control their increased saliva. Yes, Botox injections was one of them. There are a lot, but just from feedback from the patients I see, atropine has seemed to help them, scopolamine patch. But yeah, just like Dr. Reynolds was saying, there are just so many. And unfortunately, it's like, try this. Okay, does it work? No, not really. Try this. And then some of them can get kind of pricey as well. And that's a big factor. But it's really a case-by-case basis.
Yes,
just like you were saying.
absolutely. And I will say, to add on what you said, scopolamine patches, that's usually the most benign, and we usually go there first. But unfortunately, oftentimes it isn't effective. It is effective in lots of patients, but that's kind of where we start. That's the most benign.
For sure. Okay, great. Thank you. So another question that we got was about SP110, and if any of you had studied that and its relevance with its prevention of SOD1 in dogs.
Yeah. Anyone?
I have not. Yeah.
Got nothing. Okay. I am familiar with what you're talking about, and I have to be somewhat cryptic on this because at OSU we've got 3 new trials, not studies, trials that are going to be coming up with different meds, and it's not exactly what you're talking about, but it's similar. So stay tuned, folks. I can't say anything more than that.
A guy who is in my 31st year of my living with
Wow.
ALS.
Wow.
And I accredit my longevity to the keeping of my muscles moving and my tendons to stretch. And there is a routine that I found over 28 years ago, and it's in kinetics, and it moves in a 1 hour routine. Every muscle stretches every tendon that I've done for over 28 years. I think it's been a bigger part of my success. So in that hour, it moves everything. It's not an exercise, it's a movement. And I believe, and I write about it, and I talk about it, it has been my success.
Great.
Thank you.
Thank you.
Wow.
Thank you.
Good man. Okay, Zoe.
Yeah, well, that was great to hear. Another question that we got, I think this is the last question so far, is the trial for Ancillary ALS has been going on at Ohio State for 3 to 4 years. What have all of you learned to help the patients so far?
Okay, we just finished data collection. It's not just at OSU, it's with multiple large universities on the Northeast coast, okay, the Atlantic coast. So there's multiple institutions, and our data collection has been huge. We're very, very excited about it. But as far as collating the data, we've just started. We just finished seeing patients, and it will be, at least 4 or 5 months before we can put all that together and be able to put that out to the public, to you guys, so we need to make some sense out of it. So that's what we're trying to do right now. But as far as data collection, we're done. We're done.
Beautiful.
And I'm on the board of Ancillary ALS, by the way, so.
Yeah, okay, great.
Okay, and somebody else just asked what kind of data you collected.
I can answer. We have the omics data, a lot of the, genomics, transiomics, proteomics, and also iPSC cells. So we were looking at the cells of the ALS patient. So the goal is to make it all available for free for all the researchers. So we pretty much 3/4 of the way there to collect all the data, and we did the first release. So we will have, actually next week, we're kicking off some, Kaggle is a challenge, so data challenge. We invite a lot of people to take a look at the data and come up with what they're gonna find. So we're really, looking at, for the first time actually, collected so much data about ALS patients and letting a lot of the researchers do analysis on the data too, so that we can actually find, some interesting findings.
Gerald, Afia, and Silver, is there anything that you would like to leave us with this evening? And we can start with you, Jerry.
Oh gosh, hope, optimism. We are working like maniacs on this, and the people in the research field and medical field, and there's many super dedicated people, and we are busting our butts to try to get this figured out and make sense of it. And please don't give up hope. There is optimism, and ALS is different in every single person. And some people won't do so well, and other people, with all the therapies that we can help them with, will live for a very, very long time. So there is room for optimism, and we're working on it.
Thank you very much. Afia, is there anything
Yeah,
you'd like to leave us with?
Sure. I agree with Dr. Reynolds. Yes, hope for sure. We're always praying for a cure. Where I work, we would be out of business if there was a cure, and we can't wait for that day. I think be careful with when you start looking online when it comes to COVID, and this, you know, there's so much information. You can go into a black hole of information, and in general, there's already so much, but when it relates to ALS, so just be careful with that. We you know, we see, like I said, majority ALS patients. We have somebody who was diagnosed 18 years ago. She's doing okay, and she attributes her, you know, success and to doing her therapy, to doing exactly what she's, you know, using the ventilator, doing all her therapy, doing her treatments. So I encourage you guys to do that, and we'll keep you guys all in my prayers. But there's definitely hope.
Thank you. Anafia, would you like to say anything?
It's Silver.
Oh, Silver, excuse me. Thank you, Indu.
So I want to finish with like the another tool that I want you guys to use, called like a visualization. Those days that you are so tired, so exhausted, you feel like you cannot move any part of your body. I want you to sit with yourself with your eyes closed, and then visualize the part that you feel like you're having hardest time to move, or like do things like your body part that it doesn't listen to your command. I want you to close your eyes and visualize that part of your body moving the way you want. So like, you know, we know that using the functional MRIs, if I raise my hand like this versus if I close my eyes and I just try to imagine visualizing me moving that arm, the same part of the brain lights up. Yes, so there's like a difference in how bright it is, how not bright it is, but still we are stimulating the same part. So I want you to use that, the technique of visualization for your benefit. Use that. And then lastly, as McFinn said last week, be positive. That's it. That's all we can have. I think that is the biggest power we have. So I want you to stay positive and use visualization.
Thank you.
Thank you,
That's
Silver.
excellent. And we can all use it every day, being positive.
Yes.
Yeah.
Thank you so much. So
And-
everybody, we are going to unmute you all and let anybody who would like to say something step forward. So,
McFinn,
yes.
this is Debbie. We just have a couple special guests. Jamie, are you still on? Could you unmute yourself?
I'm here.
Okay, so Jamie, could you introduce yourself? Because we're here in the Northeast, so I just wanted to introduce Jamie to you all.
Hey, everyone. I just thank you for letting me be a part of it. I think that Afia, Gerald, and Silver, you guys were amazing. I learned a lot that I can take back to our clinic team here in Philadelphia. Really important stuff to hear and listen. That way we can go back to our clinic and help our patients. Unfortunately, we're doing a lot of telemedicine now, but what you guys have shared today is very important. So thank you for that opportunity. And I see some patients on there on this Zoom, and I'm very thankful for you joining today. It's really good to see you guys and connecting with you guys today. I want you to know, everybody that's on here, we're all in this together, and we're fighting for you, and we're working hard for you, and we're going to find a cure for you. And you know, we love you. This is what we do, and we're so seeing you. I think it was Rich. You're the one who talked about the stretching for 28 years. That's motivating to me. And that's going to make me fight harder for everyone tomorrow with your inspiring words. So I'm blessed. I'm thankful to be here today and to join you all. And but thank you to Afia, Gerald, and Silver, and thank you to McFinn, and thank you, Deb, for inviting me today. Thank you so much. I'm grateful.
Thank you.
Thank
And,
you. Is there any?
Yeah, I wanted to introduce, I think Jeremy actually, he's here and he's from Smile Inside. And, you know, he's so inspiring that going through ALS himself, he's still founded Smile Inside. Thank you, Jeremy, for joining. He said, I will provide telehealth clinical social work services to people with ALS and their families throughout United States. Folks who need someone to chat with can reach out to me by emailing jeremy.vantress, that is VANTRESS @smile-inside.org. And we'll send that information. Thank you, Jeremy. And also, I want to call out to Jonathan. I don't know if Jonathan, you're still here and you can speak a little bit. Jonathan is from Breathe for ALS, and tomorrow he's got a session actually on Thursday. If you go and look up at Breathe for ALS on Facebook, I think Thursday, tomorrow afternoon, there is a session where he actually goes through some breathing exercises.
Great.